Okay, so good afternoon everyone. My name's David Taylor. I'm the Managing Director for Medax Global Group. So Medax Global Group is a global healthcare workforce solutions company providing an array of healthcare workforce solutions to hospitals all over the world. So I'm fortunate enough to be based in the slightly warmer climate of Dubai in the UAE. So I've flown in today to see, well not today, that would be a miss. Flown in yesterday to see you all today and speak with some of my colleagues. But I thought I wouldn't miss out on this opportunity. Having had 3 years living in the UAE, which is obviously a fantastic place to visit for holiday, nice place to live, good education, and great healthcare. But I wanted to start today by just saying thank you. And I want to say thank you because I've got a room full of the NHS. Prior to me moving out to the UK, I've enjoyed a fantastic time where my 3 children have been looked after exceptionally well, and I don't think we say thank you quite enough. So I wanted to take the opportunity today to start my presentation by saying thank you. Living overseas for the last 3 years just makes you realise how fantastic the NHS is. All my clients over in the Middle East and Asia want to replicate what we do here, and not having that on your doorstep, you truly do notice it. So thank you. I've now got you all on side, so you'll all clap at the end. So looking at the historical landscape, I'm talking about the impact of staff on staffing. And if I look at where was the biggest impact on healthcare in general in recent times, what was it? What was the one thing that's really given us a massive paradigm shift in terms of healthcare delivery? So if I surveyed the room, I'm guessing some people will say it's some kind of medicine, whether that be penicillin or such, or some kind of surgical procedure, a procedure that's now being delivered that's had a massive impact on care delivery. And you'd actually not be correct. The biggest impact on our healthcare system in recent times was the introduction of a clean water system. That one thing was the paradigm shift which has absolutely impacted healthcare, and even though we've seen significant change since that time, we've not experienced a paradigm shift. In my opinion, we are about to experience that now with the impact of technology in healthcare. So if we look at a traditional operating model in a hospital has an operating budget. Now, some people argue the percentages here, so I've been conservative. Around 50% of the hospital budget is spent on staffing, so it's not a small amount of money. So when we look at how traditionally we staff hospitals with the physical bodies, people turning up to deliver the care, etc., we know that there's a percentage of that healthcare that's delivered by the physical body that never meets the patient. So there is healthcare delivery that's happening, and in your patient journey you never meet some of the people that are actually giving you that care delivery. We don't know what the study is, but there's a percentage of those people that could be delivered in a different way, i.e. remotely or through technology. So if we look at a traditional journey today, the customer, the hospital, the clinic tends to come either to their own HR department or in our world to the staffing agency, and the staffing agency delivers a physical body. So that person gets put in a box, sent to the hospital, locum or permanent, and delivers the healthcare. We're pretty good at that. We understand how that works. Our competitors understand how that works, and it's a model that's been around for many years. We've been in business for 30 years. It's not perfect though. We've got lack of candidate availability. We've got lack of specialists, and it's very expensive. You know, there's been massive push towards reducing locum rates, standardising locum rates in the NHS. Done a fantastic job in doing that, and we've worked with our clients to try and work with implementation of staff banks and managed service contracts to absolutely deliver that. But it's not the future, and it's not going to be all that we can do. What we're not very good at is delivering the workforce virtually or through technology, particularly artificial intelligence. And we need to get to a position where as a business we have to adapt and evolve our models to work alongside your objectives in the delivery of that care basis. I am not talking about replacing doctors with robots. This is not what it's about. We are always going to need the actual doctors to deliver certain procedures. Absolutely not what this is about. What I'm talking about is actually delivering the care better, faster, cheaper, more efficiently, and in line with the objectives of the NHS and obviously the government. So if we look at what we've done, we've developed effectively an e-health platform. The platform works across 4 areas. I've had the pleasure of speaking to quite a number of people along with my colleagues today on the stand, so apologies for repeating some of this. So yeah, it works across 4 areas, the first being diagnostics, starting off with radiology. I'm going to give you a detailed example on radiology in a second. This is not just about implementation of teleradiology. That's not new, it's not groundbreaking. It's already out there in the market today, but it's a spin on that, which I'll come back to in the example. Tele-education, needs-based medical education. That's not going to a conference, £250 train fare to Birmingham and back, sitting in a room playing Candy Crush, listening to a speech that you're not really interested in, just to get your slip of paper to say you've done your 4 or 5 hours credit. This is about what is it you need to know, who do you want to teach it to you, and who's the best in class to deliver that education. The best in class are not on stage teaching it because they're busy. So this is around connecting those specialists, again, to the audience of needs-based and just connecting the dots. So as previous speakers have spoken about, it's not about the technology. I haven't built a fantastic e-learning system. There's hundreds out there working perfectly well. It's about the way we use the technology. We create the virtual medical school in order to deliver that education to the people that need it. Teleconsultation. This is either doctor-to-doctor consultation or doctor-to-patient consultation. Doctor-to-doctor, again, is around where we've got specialists, particularly in disparate geographies, and we've got specialists needing to support colleagues in far areas, in remote areas, or in areas where they just don't have that knowledge, being able to teleconsult in doctor-to-doctor, or doctor-to-patient. Doctor-to-patient allows you to create a virtual clinic and effectively expand the physical wall and the physical reach of that hospital setting, or get to the remote areas that you currently can't get to for the people that need it. An example of that, we've got a paediatric consultant in Alder Hey Children's Hospital, Liverpool, driving to Cumbria every other week to deliver paediatric consultation clinic. Takes 3.5 hours to get there, 3.5 hours to get back, and then he sees a few patients in the middle. That's not a good effective use of time, so ultimately the teleconsultation platform allows us to expand the reach of that person's clinic and see more patients. Remote patient monitoring. So this is twofold. Remote patient monitoring is around monitoring people in the comfort of their own home that are suffering from a chronic disease. So Bluetooth enabled kit placed into a patient's home, the example being diabetic, that effectively has a care plan devised, and intervention creeps in when they're outside of the levels. And that goes back to the actual monitoring centre within the actual facility. Or taking a physical clinic in a box, I can't think of any more technical term to put it in, taking a physical clinic in a box and taking the clinic out into the community, or out into the care home, or out into the construction site where the workers are, and taking that absolute certified technology from the hospital facility into the community. We're talking a box that will fit on an aircraft cabin as hand luggage, that's got a 12-lead ECG, it's got ultrasound, it's got an ophthalmology camera, it's got a dermacam, it's got a teleconsultation platform built in, it's got medical records stored, so it's got everything that you would expect to find in an actual physical clinic. So let me go back to diagnostics and give you the example specific to diagnostics. So if we had an NHS trust, Trust A, would, in the radiology world, load their images onto their PACS system, which would effectively be integrated to our eHealth platform. As soon as it's loaded into the system, whereas currently, if they're not doing anything other than utilising the resource they've already got, they've got one option. It sits there until it gets reported on by whomever is available to report on it. We're looking at expanding this and giving them more options. So option one would be they do it themselves, exactly as they do today. They don't see any difference. It's gone into the platform. They've got the capacity within the trust to deliver that, to read that report. They're the right person to read that report. I'll come back to that in a second. And ultimately, they deliver the service, no additional cost to the NHS. Option two would be, if we had a group of trusts, start to get a little bit more interesting. If we had a group of trusts, we've got an opportunity now to look at where we've got utilisation and capacity to share some of the resource or support the resource that's already within the NHS. The example I give here, if I was to staff the NHS today as one hospital with multiple sites, the manpower planning would look very different than how it looks today running as individual trusts. So taking that analogy and just using it on radiology, I know now that within your hospitals, your subspecialist radiologists will not be doing 100% of what they've spent years training in. they'll probably be doing 80% general and 20% of what they've trained in. So effectively they're eroding skill sets, they're becoming less accurate over time, and they're not doing what they've spent years training in. So this will allow us to actually get all the paediatric cases to the paediatric specialist in that hospital, send all the musculoskeletal work to the MSK person up in that particular trust, and share the resource. Again, NHS has not spent any more money. Option 3 would be a wider trust. So this now is going from Wales to Scotland or Scotland to the UK. It doesn't matter. As long as they are registered and they're in the NHS, job done. Radiology is a high demand specialty in terms of, we struggle to recruit them ourselves. So option 4 would be, if we can't give you that person within what you've already got, go and use somebody from one of our networks. So we've got a group of agencies that we obviously run, Medax Healthcare, Doctors on Call, Fast Response, Global Medics, are all our businesses sitting under Medax Global Group, and they have a network of radiologists that currently do locum, expensive locum work, where you're booking them for a week or a month. They would do this on a study basis, so we need them to report on these 150 studies, backlog, etc., and it's a price per study. If we still can't deliver it at this point, then we go to the traditional network, which is a network of teleradiology companies. So you can see the way we're approaching this is not about trying to take technology and say, go out and partner with a teleradiology company, because they've gone out and employed 20 radiologists and they're selling you their services of those 20 radiologists. Again, you've got the subspecialty issue, and again, you've got the capacity issue, if they're busy or they've got too many people. This is around resource sharing and optimizing what you've already got. And then the report goes back to Trust A at the start. So to summarise, it's very quick 20 minutes. To summarise, our eHealth platform and the way we're trying to utilise technology to deliver outstanding care, deliver better care, will give us improved access to specialists, improving the quality of what the patient is getting delivered, obviously improved efficiency. In some examples, we see a reduction in FTE because you're staffing the hospitals collectively rather than individually, which means a reduction in cost, and the biggest factor here is obviously an increased care delivery for that patient. Thank you very much for listening.